Good morning and welcome to this morning's morning meeting. Just letting folks into the waiting room from the waiting room real quick before we kick off. All right, thanks for being here, everybody. We're really excited about our guests today. Before we dive into our content, as usual, we'll just share a quick legislative update about what's been happening here in Ohio. I'll note a few of our team members are on the Hill with First 5 Years Fund today. So good luck to Linan and Sarah and Mary Jane as they're fighting the good fight, trying to help put some support together for appropriations. Um, we are also happy to share that it is Head Start's 61st birthday. Julie can correct me, or her team can correct me, but happy birthday to our Head Start friends. Thank you for the incredible work that they do. Um, Friendly reminder, there is currently an NPRM available on regulations.gov. We'll put a link there in the chat shortly where you can weigh in on proposed changes to Head Start rules around workforce provisions. I might tap my friend Melissa. I bet we'll be able to dig that up and get it in the chat here while we're doing our updates. Congress is continuing to work on reconciliation package and farm bill. We expect House appropriations to put a markup out on June 5th. We got that information this week, so mark your calendars for June 5th. We'll keep you posted on our weekly newsletter, and we have our ongoing advocacy alert that we can pop in the chat as well. Here at the State House, the legislature did return in earnest this week. They are all over downtown, man. They had House Children and Human Services Committee earlier this week. They adopted a sub bill for House Bill 649. Minimal changes. That was one of the two program integrity bills. The language changes were not substantial, but they did incorporate some language related to how the Inspector General communicates with the General Assembly and with DCY. And additionally, the committee adopted changes to House Bill 635. This is child welfare legislation that we provided testimony on last week. It would adapt language around local law enforcement's role in communicating a history of domestic violence, where the original bill had required law enforcement to input this data directly into the child welfare database, which you might know as SAQUIS. Amendment requires law enforcement to report this information directly to the local PCSA. There were no votes in the committee this week, just some updates to bills, and we'll keep you posted in our newsletter around notices for next week as they continue to roll out. Yesterday, Senate Health Committee heard Senate Bill 267, which is from Senators Craig and Reynolds, a bipartisan effort to create Doula Awareness Week. The committee received sponsor testimony and a good amount of questions from the committee chair around the nursing board data that's been shared with the General Assembly around Medicaid reimbursement. More to come on that. It was just sponsor testimony, no other testimony yet. And we're hoping to meet with some legislators from that committee offline and chat more about that bill. And finally, Ohio's Medicaid program is facing a lot of scrutiny this week. I'm sure many of you have seen media coverage around claims of fraud. The House Medicaid Committee did meet and had a pretty heated testimony Tuesday afternoon from a reporter from the Daily Wire who spoke about his investigative reporting. Lots of pushback from the committee members. It got a little bit heated. Governor DeWine has been very outspoken about this issue and you know, been very clear that Ohio's Medicaid program has been acting with integrity to address any challenges and being proactive about fraud prevention. So more to come on that, more to come on all of the things. Without further ado, feel free to let us know if you have questions on any of that, but I wanted to make sure we get lots of time with Hallie and Sydney. So Hallie, I'll just share a quick headline background on each of them and then let them dive into the work. Hallie serves as the coordinator for Ohio's Pregnancy-Associated Mortality Review Committee at Department of Children and Youth. And she has her background in public health and a master's degree in population health management from OSU. And we also have with us Sydney Tavens. Tavens? I'm hoping I'm saying that right, Sydney. And she is the data analyst for the Ohio Pregnancy Associated Mortality Review Committee at DCY. And her background is also in public health, where she has her master's from OSU as well. So we're really excited to welcome them back. I was just sharing before we had everybody in that Hallie and Sydney are one of our first time return presenters. So we are so grateful for the work you do and really looking forward to hearing an update from you both today. I'll turn it over to you. Thanks, ladies.
Thank you. So grateful to be here. So grateful to be presenting this data again and sharing this with everyone. I'll go ahead and share my screen. Is everything looking okay over there?
Looks perfect.
Awesome. So Thank you again. So happy to be back. We're just sharing a bit today about Ohio's Pregnancy-Associated Mortality Review and in general MMRC's maternal mortality review committees, and then also sharing our most recently updated 2021 data and a little bit about the PAMR process. And so I'll go ahead and start with a quick agenda. So this is our agenda for the day, first going through our acknowledgements, and then we'll do a quick review of the various sources of maternal mortality data that exist, which is going to serve as a great transition into a brief overview of our very own PAMR process. I think a lot of people here may be a little bit familiar with the PAMR process, but it's always worth a good refresh to look it over. And this year, we also thought we might provide some additional context around our process by sharing some measures that we collect as a part of our work with the CDC. And then the main event, we will take a look at the data from the 2021 PAMR report as well, looking at different trend analyses with the available PAMR data from 2008 to 2021, and then opening up some time for any questions or discussion at the end. And so getting into it, just looking at the acknowledgements, anytime that we are talking about PAMR data, it's really important to acknowledge that these numbers represent lives lost. Each life lost was a whole human being with their own hopes, experiences, and their own way of moving through the world. However much we may understand, we can never truly know the whole of a life and these lives that we review in our work. And still yet we truly do honor the fullness of their lives and recognize the depth and humanity of every life lost. And so this report is dedicated to the memory of the 140 individuals who died during and after pregnancy in 2021 and their loved ones. And it's this work that requires so much dedication and support from so many people, including the PAMR committee members who volunteer their incredibly valuable time and energy, the staff at the state who live and breathe this work, and especially our incredible nurse abstractors and our partners at the CDC for their guidance and support. And we'd like to thank you all for being here today and looking at this data and looking at this work with us, and for doing the work of preventing pregnancy-related deaths. And continuing, I thought it might be a little bit helpful to share, even beyond PAMR data, the other sources of maternal mortality data sources that exist and might be seen out in various news articles and articles out in the world. So sharing this table here, on the left we have national data sources headed by the CDC, the NCHS, and the PMSS. But then on the right we have our very own data, maternal mortality review committees and pregnancy-associated mortality review. There's a lot more information on here. Please feel free to come back and look at this slide, but really what we want to get at with this information is that when reading headlines around maternal mortality, it's so important to note the various data sources and what data source is being cited, what measure of maternal mortality or pregnancy-related mortality is being used, and if and when it's available, reviewing the methodology for the data and for the analysis can be incredibly helpful also. It's also really important to note that if data is being presented from different sources, we're not able to compare across these sources just because of how the data is pulled and what it's really looking at. And then the last thing I really want to drive home is that it really is the data that comes from MMRCs and PAMR that is the most accurate and complete data addressing maternal mortality and pregnancy-related mortality for a state, and when the data can be pooled for a nation, for the US, it really is the gold standard. And because of all of the work and time that goes into it, it is usually the most delayed of the three data sources due to that in-depth review process. And then I'll go ahead and pass it off to Hallie to look at our PAMR process in more depth.
Thank you, Sydney. So, um, So it started to touch on some definitions as we're looking at those different maternal mortality data sources. I'm going to echo her here that they're measuring slightly different things, so it's important to note those, most importantly being what causes of death are captured and the timing. So in Ohio, when we're talking about Pregnancy-Associated Mortality Review, or PAMR is our definition, that's the same thing as an MMRC, or Maternal Mortality Review Committee. Those two acronyms get tossed around, but if it's operating at a state or jurisdiction level, those are one and the same, and these are the definitions that we use in that space. So, to begin with, we have pregnancy-associated death. This is the death of a person during pregnancy or within 1 year postpartum, regardless of the cause. This really makes up that initial group of deaths that PAMR will start with to begin reviews for all of those deaths that meet that definition within a year's time frame. From that list of deaths, we are working to determine if a death is pregnancy related. That would be a death that is directly caused or influenced by pregnancy. And one of the ways that the committee can determine this is by asking, would this person have died if they had not been pregnant, or did pregnancy play a role in this outcome? And then, so from that, you can either determine if it's pregnancy related. If it's not, then it's pregnancy associated, but not related. So it just met that time frame, but pregnancy did not play a role. And then occasionally we have unable to determine cases. This is often where we don't have sufficient records or information to determine if pregnancy played a role in that case. But we work really hard to have a multidisciplinary committee so that even from the information we have, we get as close to one of those, making a determination on those either way. Next slide. So then this is just a quick graphic about how we get a pregnancy-related mortality ratio. We just take that number of pregnancy-related deaths and look at it over the number of live births within that same time frame. This example here is showing you how we got there for 2021, and then it's expressed as a ratio per 100,000 live births. It's 100,000 live births because while these deaths happen far more frequently than they should, they are still a smaller number, so that's why we express it as a ratio in this way. And it's important to use a ratio to help provide context within the context within which this problem is happening. It puts that number into perspective in a way that a count just can't do on its own. And it also allows for comparison of this issue when we want to look at it over time or between demographic groups or occasionally between states, as long as you know you're looking at that same year's worth of deaths. Next slide. So again, as Sydney mentioned, MMRC data, like PAMRs, is the gold standard when it comes to maternal mortality data because it not only gives us more precise and accurate cause of death information, but it also offers insights into the other factors that surround a death, like preventability. To achieve that level of depth and quality in data, it takes really coordinated efforts between our team, a lot of time and energy, and across this iterative process with lots of moving parts. This visual is our most recent attempt to offer kind of that bird's eye view of our process and demonstrate our commitment to transparency and our efforts to achieve more timely data. So I'll just walk us through here where we first start with Sydney's work to identify all of the pregnancy-associated deaths in our calendar year. We just went over that definition, so that's anybody who died within a year of their pregnancy or while they were pregnant. And then part of this work includes confirming that these deaths in fact meet that definition. This is often times where we're unable to link a birth certificate. A death might require a little bit more work to confirm that it meets the definition. She's currently completing this work for deaths in 2025 and 2026. The next step is from our confirmed list, our nurse abstractors and administrative professional. They get to work identifying records that need to be requested. This is mostly healthcare records, but it can also look like things like emergency medical service records, law enforcement, child protective services. We also look at obituaries, social media, news articles, anything that we think helps tell that story. And this records requesting is a big piece of this puzzle that does require a lot of time, especially because some of that time is not always up to us. Sometimes we get records back in days and sometimes we get records back in months. But we do continue to try to refine this process to the best of our ability. And then once all the necessary records are received, the abstractors help piece together the chain of events that led to the death. They then create a de-identified case narrative that offers all of those pertinent pieces of information to construct that chain of events for our committee to review. We then take those de-identified case narratives to our multidisciplinary committee for them to review and determine our key questions and document these on a standard committee decision form that's created by the CDC. And we are currently completing all three of those steps. So records requesting abstraction and committee review for deaths that occurred in 2023. And finally, once all the deaths from a calendar year have been reviewed, Sydney picks them back up again to analyze the data from our committee's decision form to create our reports and generate other analyses. To borrow an analogy that she uses, she likes to say she's the bread in the Pammer sandwich, where she starts with the case list and then she picks it back up when we're ready for that data analysis. And so we just completed review of 2022 deaths, so she's now able to begin diving into that data. And then the final step is one that is a perpetual step where we continually look at the data to see how we can use it to inform our work that we do to improve maternal health. And then we also want to do things like this, where we're making sure that we get the data into the hands of folks like you and others out here who are doing the important and necessary work to change outcomes for pregnant and postpartum people in Ohio. And the data that's currently available to us to inform the work that we do now is that from 2008 to 2021. So one of the things that we hope that you can take from today is ideas or at least a curiosity about how to leverage this information in the work that you do. And I will pass it back to Sid to talk about said data.
So looking at 2021 data, the report is available on the DCY Pammer website, but we thought we'd take a couple slides here today to get into it. Starting with the key findings, I want to first start by reviewing a lot of those major findings that we were able to pull out from the 2021 data and summarizing kind of the key insights that we were able to glean from the report. First, noting that over 1/3 or 36% of pregnancy-associated deaths were found by the committee to be pregnancy-related. And then second, of those pregnancy-related deaths, the vast majority, or 88%, were preventable as well. And then continuing with further analyses, looking at stratified analysis by race, ethnicity, and cause of death, 2021 data found that non-Hispanic Black women were disproportionately affected by pregnancy-related deaths, and COVID-19 had a considerable impact on pregnancy-related deaths in 2021 as well, with the leading cause of death, pregnancy-related death in 2021 being infection at 35% of all pregnancy-related deaths, of which a majority of those deaths due to infection were more specifically due to COVID-19. And then lastly, a majority of pregnancy-related deaths caused by infection, 88% were also determined to be preventable by the committee as well. And so before we begin reviewing more specific data looking at the causes of pregnancy-related death in 2021, and with an infection being one of the leading causes of pregnancy-related death for 2021 in Ohio generally and nationwide, I want to first explain some of the nuances that kind of live around infection-related causes of death in our data. And I think a simple analogy can kind of help make this clear. And so here on this slide, we have a screenshot of the PMSS codes in the data. These are the codes that we use in our data to kind of help us code the underlying cause of death. And so that underlying cause of death is really kind of what sets off the chain of events that then leads to the immediate medical cause of death. And so when we're looking at that larger infection umbrella that we use during our analysis of pregnancy-related deaths, these are the codes that the committee selects that fall under that umbrella. So when the Pammer committee is classifying infection-related deaths, they have the option to select a more specific underlying infection, such as pneumonia, urinary tract infection, etc. But then they also, as you can see in this list, have the option to select sepsis/septic shock, and that's when the exact source of the infection can't be determined. So to kind of understand this distinction, looking at that analogy, it can be really helpful to think about sepsis the way that we might think about a house fire. So if firefighters arrive early enough to the scene, they can often identify exactly what sparked the fire. This might be a candle or some faulty wiring. And so in the case of infection-related causes of death, this might look like sepsis, but there's a clear evidence of a UTI, a postpartum genital tract infection. There's really that clear evidence for the source infection that started that chain of events. But if the fire has burned too hot or the fire has burned for too long, the damage can be so extensive that the original cause of the fire is impossible to identify. And so, with that analogy, comparing back to infection related causes of death, sepsis really works in a similar way. So, sometimes we can clearly identify the infection that triggered it, and other times, all we can really see is that overwhelming inflammatory response. And so this is all to say that on occasion, the Ohio PAMR Committee can use all available case records and the content of those records to try and make the decision and identify the source of infection. However, sometimes the necessary evidence to determine that underlying infection isn't available. So that's when that sepsis septic shock coding is used for coding the underlying cause of death in the data. And so continuing with looking at the data, in 2021, the leading cause of pregnancy-related death was infection at 35%, including that sepsis/septic shock. However, the vast majority of these deaths were due to COVID-19, which made up 31% of pregnancy-related deaths overall. And other leading causes of death, pregnancy-related death for 2021 included mental health conditions, thrombotic embolism, and non-hypertensive cardiovascular conditions, which includes cardiomyopathy. And so continuing with that, we also have a graphic that breaks down the cause of death data even further, both by the leading causes on the left and then other causes not found in those leading causes on the right. And as I said with the previous graphic, this year and moving forward with our data, we're working to combine what was originally other cardiovascular conditions and cardiomyopathy originally in separate categories, but now into a single reporting category that is looking at non-hypertensive cardiovascular conditions. And so we did this with the guidance from our internal clinical PAMR staff members, really trying to improve the clarity and usability of our data. And ensure that when we're grouping this, that these conditions are sharing similar clinical trajectories and risk profiles, and that the implications for maternal care that we pull from this data are still similar in what we can do with what the data is telling us. And then continuing with leading causes of death, but breaking it out by race ethnicity. You can see here for 2021 that the leading causes of pregnancy-related death do vary by race ethnicity. For those infection, mental health conditions, thrombotic embolism, and cardiovascular deaths. And then continuing with racial disparities in pregnancy-related deaths, as presented on the key findings slide, there was a disparity in 2021 and overall within Ohio data, where in 2021 specifically, non-Hispanic Black women were 3.2 times more likely to die from pregnancy-related causes than non-Hispanic white women. And we want to call out specifically that racial disparities between non-Hispanic Black women and non-Hispanic white women remain, regardless of the COVID-19 related mortality that appeared specifically in the 2021 PAMR data for Ohio. Continuing in 2021, similar to years prior, a majority of pregnancy-related deaths occurred during the postpartum period. Specifically in 2021, more than 3/4 of pregnancy-related deaths occurred during the postpartum period. And then looking at the timing by the leading causes of death, this is one of my favorite analyses to show, as it really gets at when you're stratifying this data, really looking at opportunities and understanding where intervention and preventability can be made. And then I'll pass it off to Hallie to look at more of our qualitative data.
Thanks. As Sydney said, this is where our qualitative data that comes from the committee review comes in. So especially when folks are considering timeliness and wondering how relevant some of the quantitative data is for them, we recognize that that's a question that folks have. I would encourage you to then look at the contributing factors and recommendations that are in the reports, as these can be more evergreen and they continue to highlight places where we have opportunity to make changes and improve outcomes. So contributing factors are specific circumstances that the committee members identify that could have prevented the death. And this can look like unstable housing or issues with care coordination, issues with access to needed care, chronic disease, trauma and violence, and more. These are organized based on a prescribed set of categories of contributing factors that's set by the CDC. And in 2021, there's a total of 185 contributing factors that were identified among the 42 preventable pregnancy-related deaths. The majority of these contributing factors fell within these five classifications here on the screen, including things like lack of adherence to medical recommendations. This can be at both the patient and provider level, looking at problems with clinical skill and quality of care, issues with care coordination, an inadequate assessment of risk, and then delays in care. Next slide. And then by identifying those contributing factors, the committee then creates a specific and actionable recommendation that they believe would address that factor they've identified. These are written in a who, what, when format. So who should do what, when. And these are the recommendations that anyone looking to improve maternal health in Ohio can turn to for inspiration and direction. This is a sampling of some of the recommendations from the 2021 report. And these are the recommendations here, or some of the recommendations here reinforce some of the work that we're doing here at the state, like this recommendation in the fourth column that's speaking to the protocol of the AIM patient safety bundles to address severe hypertension in pregnancy. This is a project that we've implemented across the state since 2020. Another recommendation speaks to the importance of sharing the urgent maternal warning signs far and wide. This is something we've done in the past, and I know others around the state continue to share that education and those resources so that everyone interacting with pregnant and postpartum folks can support them in recognizing these concerning symptoms and then what to do about it. As I said, these are just a sampling, so I encourage you all to spend some time with the report and even past reports to look at the recommendations when you're considering or when you have considerations for your work in this space.
And then to wrap up our presentation today, just looking at some PAMR data trends from 2008 to 2021. Some of these graphics can also be found on the DCY PAMR website. Starting with looking at the 2008 to 2021 pregnancy-related mortality ratio, we can see that with the introduction of the 2021 data recently published, that pregnancy-related mortality ratios have increased from 2008 to 2021. And then continuing with pregnancy-related mortality ratios broken out by race ethnicity, we can continue to see that racial disparity discussed earlier among non-Hispanic Black women in comparison to the Ohio overall PRMR and the non-Hispanic white woman PRMR. And continuing looking at the leading causes of pregnancy-related death, we can see the non-hypertensive cardiovascular conditions from 2008 to 2021 were the leading cause of pregnancy-related deaths in Ohio, followed by infection, mental health conditions, and more. And finally, wrapping up the 2008 to 2021 data, we can see that in Ohio, most pregnancy-related deaths, specifically 71%, were determined to be preventable by the committee. And although Ohio PAMR has not always determined preventability for all pregnancy-related deaths since it started with 2008 data, I'd like to note that this analysis is only including those deaths where the committee determined and discussed preventability during review. And that concludes our presentation for today. Thank you all so much for having us again, giving us this opportunity. And I know we only have 1 minute, but we'd like to open the floor to any comments, discussion.
Thank you, Sydney and Hallie. It is so sobering, the data that you've shared, and I really appreciate the context and the slide that you shared at the outset to center the pregnant folks that we are talking about this morning. Does anybody have a question that they would like to share in the chat or hop off mute to share with Sydney and Hallie? And we appreciate the contact info in the chat as well. I linked the report. Our team's already talking about how we can share out some of this data and hopefully activate some advocacy around interventions. And just really can't thank you enough for the integrity of the data that you share and and just the details of the process. It's incredible thinking about even just the records request portion alone. As you were chatting through that, I'm just my gears are turning, and I'm just so grateful for the amount of of care and attention to detail that goes into this work, and it really makes us feel confident in sharing out the data. So thank you for bringing such care to this work.
Thank you for having us. We are continually grateful for opportunities like this to be able to talk about this with folks outside of our team, because sometimes we feel like we're, screaming into the void a little bit, or so any chance we get, we are always helpful. And yeah, the email's in the chat. So if you have questions about the data or the work that we're doing or any and all of it, we are always happy to connect. Thank you.
Thank you, Hallie and Sydney. And I would just charge everybody who called in this morning to share out one of the facts you learned today, because the more we can share this out, the more likely we can help improve outcomes for moms. Thank you, Hallie and Sydney. Have a wonderful day, and we'll keep in touch soon.
Thank you.
Thank you.
Thank you.